Alrighty, y'all. So this week's research spotlight is a review article from 2015, Determinants of sit-to-stand tasks in individuals with hemiparesis post-stroke, a review. And I like this article because last week I had to use it I decided to use it for a mentor prep form for one of the mentor sessions for the residency, kind of surrounding task analysis. And I thought it did a really good job of breaking the task of sit to stand up into different pieces, kind of talking about typical sit to stand in non-pathologic individuals, and then it talked a little bit about some of the things that you see in patients post-stroke. So in this article, they divided sit to stand, which is a very basic task that everyone thinks that isn't too complicated, that we all do every day, and they divided it into 4 different pieces or phases. And phase 1 is the initiation phase, or the flexion phase is what they refer to it in this article. So referring to the truncal flexion or the hip hinge that occurs in the beginning of sit to stand. The second phase was the liftoff phase. So when the weight actually starts to transfer from the pelvis on the chair into the lower extremities, and when the buttocks actually comes off of the chair, so when you actually get that lift off. Phase 3 was the extension phase, so when you start to get hip and knee extension and ankle plantar flexion, and you start to get more of that superior translation of the center of mass compared to anterior superior. And then the final phase was termination, or the stability phase. So I thought it was nice how they kind of broke sit to stand up into those 4 different phases, because they're all different components of sit to stand that need to be addressed in somebody who's having difficulty with performing the activity of sit to stand. And I think it mentally, when I think of those phases: flexion, okay, I'm getting hip flexion. Lift off, okay, that's when the butt comes off. Extension, okay, that's when my lower extremities are extending. So it's easy to kind of remember where the different phases are. The article goes into a little bit of some of the muscular activation patterns. It doesn't go super in depth, but it does go into a little bit of that. I'm not going to talk about it too much there. So that was one of my big takeaways, was kind of the different phases of the sit to stand transfer. And then also later in the article, it talks about some of the things that you see with patients post-stroke who have hemiparesis. Talks a little bit about how they typically trunk lean kind of the opposite side, so onto their uninvolved side for a little bit of strength. And it also talked about how they typically don't have even weight distribution between both of their lower extremities. And then one of the main things that it talked about kind of overall with sit to stand is you can use the lower extremities in patients post-stroke in their initial condition setup to bias how they load their lower extremities and kind of how they perform the task. So if you put their involved lower extremity more anteriorly, so their uninvolved is behind, they're going to use that leg more, which they're already doing. So it's not what we want to do. We want to put their involved lower extremity back a little bit and bias their uninvolved lower extremity, or what they might refer to as their stronger lower extremity, forward a little bit, because that's going to encourage them to have to use their involved lower extremity. So if they're a patient who had a left MCA stroke or left ACA stroke and they were having trouble with sit to stand, their right lower extremity is going to be involved. So we're going to put their right lower extremity back a little bit, bias it into a little bit more knee flexion, a little bit more ankle dorsiflexion, and have that left leg be kicked out a little bit. And then when they go to perform the sit stand, not only is it going to help with the weight distribution between their legs, it's going to kind of even it out a little bit. They saw, I think some of the studies they referenced saw like a 16% increase in weight distribution into the involved lower extremity when they biased the lower extremities like that. And then they also saw that there was a more even center of mass shift within the coronal plane. It wasn't quite as drastic, which was indicated also by a improvement in truncal alignment throughout the transfer. So I think the article does a good job kind of talking about the basic phases of a typical sit to stand and kind of where we need to be paying attention as therapists. Breakdown might be happening in patients post-stroke. And then it also talks a little bit about some of the things that you might see in a sit to stand after stroke, and kind of some things you can do to address that. And it talks a little bit about rehab. I'm not going to go too much much more in depth into anything with that. But I thought this is a good article to share for anybody that has to do any movement analysis on sit-to-stand, or for anybody that's working with patients post-stroke. I think it can kind of be a good article to review for anybody. Doesn't matter what practice setting you're in, whether you're outpatient ortho or inpatient acute, inpatient neuro, or even pediatrics, because everybody has to sit down and stand up. So that's this week's article. Hopefully you get a chance to look at it and find it helpful, and thanks for watching.